Thank you for giving me the opportunity to talk about chronic kidney disease. This is one of the non-communicable disaster. So we will talk about early detection, how could we do it, what are the risk factors, and how could we manage it well. So outline would be what is chronic kidney disease and what is the global burden of chronic kidney disease, what are the risk factors for chronic kidney disease, and how can we screen so that we could prevent and cure it. And at the end of this presentation, you should be able to screen for high-risk patients, able to know the treatment of early disease, and how early detection could be helpful. It's so very important to detect the kidney disease early on because that would allow you for implementation of the therapeutic interventions. And you could also avoid the exposure to nephrotoxic drugs. For example, if you have a patient with osteoarthritis taking ibuprofen, unless you know that that patient has chronic kidney disease, you can't do anything. Identification of chronic kidney disease as a risk factor for cardiovascular disease so that you could decrease the cardiovascular mortality and morbidity. So chronic kidney disease is basically chronic progressive loss of kidney function which is present for more than 3 months, and it does have some implications for health. And if that is because of diabetes, it could manifest in the form of albuminuria, proteinuria, hypertension, progressive loss of kidney function. That would be diabetic nephropathy. So the risk factors could be many, but the basic definition of chronic kidney disease that it has to present for more than 3 months. So this is the current classification of different stages of chronic kidney disease. Chronic kidney disease has been divided into 5 different stages based on the GFR, and that is the functional classification. As we all know, if someone has GFR of more than 90, that is considered class 1 or stage 1 of chronic kidney disease. One might ask, if the GFR is more than 90, that is normal, why this patient is classified as chronic kidney disease. So that patient, for example, if you are diabetic, that patient could have albuminuria and proteinuria. So in order to differentiate that patient from the normal population, you do have to label that patient as patient with chronic kidney disease. As we all know, early on in diabetic nephropathy, there is hyperfiltration. So that hyperfiltration could lead to increased GFR, but at the same time, there could be onset of albuminuria or proteinuria. So albuminuria and proteinuria is so significant that has been included into the current classification of chronic kidney disease. So based on the albuminuria, it's A1, A2 or A3, less than 3 milligram per gram of albumin is normal. But if someone has between 30 to 300, that is microalbuminuria. That was the old definition. Now it's currently caused moderately increased albuminuria. Similarly, if someone has more than 300, that used to be called as macroalbuminuria. Currently, this is severely increased albuminuria. And this table basically would tell you the prognosis or the risk of progression of kidney disease. Lower the GFR or more the proteinuria is, there is higher chances of progression of chronic kidney disease. For example, even if you have GFR between 60 to 90 and you have A3 albuminuria, you are at a higher risk of progression of chronic kidney disease. Albuminuria not only is a risk factor for the progression of chronic kidney disease, it is also a risk factor for cardiovascular mortality and morbidity. As you could see in this, the cardiovascular mortality as well as all-cause mortality increases significantly at any given GFR, even if the GFR is 60, but if the albuminuria is in the macroalbuminuria range, then there would be a significantly high risk of cardiovascular mortality and morbidity. Similarly, the risk of progression of chronic kidney disease also increases with albuminuria. So you want to basically diagnose your patient when they have onset of albuminuria and at early GFR. So we will be talking about early detection, and I would like you to be able to detect the kidney disease when it is at stage 1 or 2. So the global burden of chronic kidney disease is increasing. This is in 2010. There were 2 million people with dialysis. Now currently 4 million people out of 850 million people total has been on dialysis. So the risk is, the incidence and prevalence is increasing significantly. and that 4 million people represent only 10% of the detected chronic kidney disease. This is an older slide. At that time, the prevalence was 10%. Currently, it's 15 or 16%, the prevalence of chronic kidney disease. So in US, they predicted by 2030, the prevalence would be 16%, but they were surprised that even in 2017, the prevalence was already 15%. So that means 1 in 5 or 6 people currently in USA have chronic kidney disease. And US have a lot of money, so they could spend billions of dollars to take care of 0.3% of the adult population. We need to spend our money at risk population and people with early chronic kidney disease so that we could prevent it, cure it, and we do not progress to end-stage kidney disease. As we all know, diabetes and hypertension are two major risk factors for chronic kidney disease, and that makes up to 70% of the cases of chronic kidney disease. And Pakistan, no surprise, is number 1 in the prevalence of diabetes currently. And the cases of hypertension worldwide has been increasing. This is undiagnosed hypertension. This is diagnosed but untreated. This is treated but uncontrolled. And very few percentage of hypertensive population has controlled hypertension. So this is more than a billion people in 2019 had basically hypertension, and most of them, 82% of them, belongs to low-income countries. So Pakistan has very high prevalence of hypertension as well. That is why the incidence and prevalence will keep on rising. So we cannot basically screen the whole population. That would be counterproductive. So we need to find out the high-risk population. So high-risk population, diabetics, all the hypertensive, and I would also include the people with the family history of diabetes and hypertension. They are also at a high risk. Family history of chronic kidney disease, age above 60, ischemic heart disease, kidney stone. In Pakistan, you could also include hepatitis C. So these are the high-risk population, and you should screen them with spot urine for albumin-creatinine ratio and estimated GFR by checking their creatinine to see if they have early disease or not. Anyone having any of these one risk factor, you should screen them. In type 1 diabetics, 5 years after the diagnosis. In type 2 diabetics, at the onset of diagnosis, and then every year. And this is how you screen. You send spot urine for albumin-creatinine ratio to quantify for albuminuria, and serum creatinine to calculate the estimated GFR. We were very curious at Jinnah Hospital, Lahore, that what is the prevalence of chronic kidney disease in high-risk population of Pakistan. So just prior to COVID, we started doing this study. Our original target was to maybe have like around 1,000 patients, but then we couldn't do it. So 6 out of 10 administrative towns of Lahore were selected, and we had the similar high-risk patient as National Kidney Foundation recommended, hypertensive, diabetic, age above 60, family history. We also included the people with kidney stone, hep C, ischemic heart disease, and in our case, we also included people who had been chronically using painkillers like NSAIDs, and also has been using herbal or Hakim medications at least for 4 weeks or more. And we tested them for urinary albumin and serum creatinine to calculate the estimated GFR. So male, female were kind of equivalent. These are the baseline characteristics. So 51% of our population were hypertensive, 42% were diabetics, 41% had family history of kidney disease. And then what we found out, all these high-risk population, we also had people with painkillers and herbal and Hakim medication use, couple of patients with history of cancer as well. So our prevalence was 24.4. So 25% of our population, that means 1 in every 4 in high-risk population had chronic kidney disease. And these people were not aware of the fact that they have chronic kidney disease. The significant association with chronic kidney disease was with hypertension. Hypertensive people almost 30%, diabetic almost 40%, and then also ischemic heart disease, people who were abusing the painkillers, as well as were taking some kind of a chemo, homeo or herbal medication. So this was a significant association that these risk factors had significantly more number of chronic kidney disease. When it comes to the management, it's very important once you have detected the chronic kidney disease that not only you are treating the underlying cause and complication, you must focus on the cardiovascular risk stratification. Because as you could see, there are so many people in stage 1 and 2 and 3 of chronic kidney disease, millions of people, but stage 4 drastically to less than 1 million. The reason for that is cardiovascular mortality. So once you identify here, not only you could treat the underlying cause as well as the disease, and if you look at all the management options for chronic kidney disease as well as cardiovascular disease are similar. So for both of them, if they are diabetic, you would like to control their diabetes very well, their blood pressure very well, complications of kidney disease like proteinuria, and then you would also decrease the risk by treating dyslipidemia, lifestyle modification, weight loss, smoking. So it's kind of similar. If you implement all these strategies, you could decrease the risk of death essentially. And in terms of diabetes control, National Kidney Foundation has recommended to bring down the HbA1c to less than 7%. Different studies have shown that less than 7% is would have a significant impact on microalbuminuria. Given the shortage of time, I'm just going to run through the slide. So once you have diabetic alone, without any hypertension and albuminuria, you do not need to use the ACE inhibitor ARB. But once you have diabetic with hypertension or albuminuria, ACE inhibitor and ARBs are the drugs of choices. The reason for that, because controlling the hypertension with the medication which decreases the proteinuria also will prevent diabetic nephropathy, retinopathy, cardiovascular disease, and so many other complications. This is the current recommendation. You must bring down the blood pressure to less than 130/80 with ACE inhibitor as well as with ARBs. We already went over treatment of albuminuria and proteinuria with ACE inhibitor and ARB. One point I would like to make, there is no role of combining ACE and ARB as indicated in on-target trial. All the other studies showed there is a significant benefit of ACE inhibitor and ARB. Combination is not recommended. So I would like to focus last 2-3 minutes on this. Till 2013 we have ACE and ARB. Now we have so many other drugs, SGLT2 receptor antagonist as well as non-steroidal mineralocorticoid receptor antagonist. And in fact they have been included into the comprehensive treatment plan. So if you have someone with diabetes, you must use SGLT2 receptor antagonist as well, even if they don't have albuminuria, because that would be the treatment of choice. And even if they are at the target, you could discontinue one of the other oral hypoglycemics and include SGLT2 receptor antagonist. And their use is quite remarkable and significant even in the early disease as indicated in CANVAS trial. And you could keep on using it as long as even if their GFR is less than 20. There is a lot of data and studies coming that even in dialysis population they have a beneficial role. The other agent I would like to talk about is finerenone. It's mineralocorticoid receptor antagonist. 2 trial, one of them Fidelio showed they have patients with very good GFR, very little albuminuria, double-blinded in type 2 diabetics, that they have significant impact not only in the cardiovascular disease but in reducing the risk of chronic kidney disease and the progression of chronic kidney disease. Then there was another trial, Figaro trial, which also showed there is a significantly decreased risk of cardiovascular disease, mortality and morbidity if you use mineralocorticoid receptor antagonist. Currently it's not available in Pakistan. You could try a eplerenone and spironolactone till we have availability of finerenone. So I would end my talk by going over the take-home message. CKD incidence and prevalence is increasing worldwide, and in Pakistan. Pakistan ranks number 1 in diabetes prevalence. Early detection could help timely therapeutic interventions, and we should use emerging therapies like SGLT2 receptor antagonist as well as mineralocorticoid receptor antagonist, and you should be very familiar with their utilization. If you ever have a patient who has a high risk factor in your practice, you should screen them by checking their serum creatinine and albumin creatinine ratio. And you should always consider utilization of renin-angiotensin system inhibitor, SGLT2 receptor inhibitors, mineralocorticoid receptor inhibitors, and there is also emerging role of GLP-1 receptor agonist as well. So if someone has a rise in creatinine up to 20%, that is acceptable. So you do not just stop the drug, you decrease the dose of the drug or you decrease the dose of a diuretic, and you could continue the drug at a lower dose so that you could get the beneficial effect in the long term in terms of progression of kidney disease. And last, identifying and managing patients who have early stages of CKD may slow or prevent the progression to ESKD and reduce the cardiovascular complications. Thank you very much.